Welcome to The Pod, a podcast for women in healthcare leadership, a heartfelt space where women executives in healthcare and their allies unite to support and uplift each other with personal stories that inspire positive change, nurture optimistic mindsets, and celebrate diverse perspectives. I'm your host, Dr. Kristen Woods. As former U.S. Surgeon General, Dr. Regina Benjamin once observed, "We cannot have a healthy society if we do not have healthy healthcare workers." And that includes ensuring that they are valued and compensated fairly, regardless of gender. Our guest today brings a unique perspective to these conversations. Dr. Rebekah Apple serves as the director of the Master of Medical Management program at Carnegie Mellon University, my alma mater, where she's shaping the next generation of physician leaders through a degree program designed exclusively for practicing doctors. With over 15 years of experience as a healthcare advisor, educator, and ethicist, she's worked across academic, clinical, and association environments, designing educational programs for healthcare professionals nationwide. What I find particularly compelling is her dual expertise in leadership development and medical ethics. She's certified to administer world-renowned psychometric assessments and currently serves as a medical ethicist at UPMC while teaching both organizational ethics at Carnegie Mellon and bioethics to medical students at the University of Pittsburgh. Her academic credentials include a master's in bioethics and a doctorate in health science. And her real-world experience navigating the complexities of healthcare leadership brings depth to today's conversation. As someone who's dedicated her career to developing ethical leaders in medicine, Dr. Apple understands firsthand the unique pressures women face in healthcare leadership roles, from managing impossibly high expectations while preserving the compassion that drew them to healthcare, to advocating for fair compensation in a field where gender disparities persist, despite women comprising the majority of healthcare workers. Today, we'll explore how women leaders can set realistic expectations while maintaining their authentic leadership style, and discuss practical strategies for addressing the gender pay gap that continues to impact women throughout healthcare. So, let's dive in. Welcome to the show, Rebekah.
Thank you so much for having me. I appreciate it.
Yeah. Well, I'm, for one, am super excited for this conversation. And you have spent your career developing physician leaders. What initially drew you to focus on the intersection of leadership development and medical ethics?
That's such a good question, and I get asked that question quite a bit. And I will say I was already involved in providing education to physicians, primarily related to organ donation and transplantation, when I started thinking about the role that physicians played in the healthcare system in general, and how they received a lot of education with regard to clinical ethics, but not so much related to organizational ethics, to their detriment. So when I'd always had an interest in medical ethics, and I thought there might be a possibility to infuse the work that I was doing with ethics as well. And it miraculously, it worked. And I continue to hope that it has really helped a lot of physicians better navigate their existing positions and also their career trajectory.
Yeah, and as you said that and talked about blending the two and that it miraculously worked, are there other people like you out there, or are you a unicorn in this space?
There might be other people. I think sometimes when you're looking at clinical ethics, a lot of organizational ethics kind of crop up, and sometimes a clinical issue can point you in a direction in terms of, organizational management, for example. So I think, there are probably a lot of people who are doing both, whether or not they're established as both, like in a public manner, I couldn't say. Okay. I wouldn't mind being a unicorn, though.
Well, perhaps you are. You've worked extensively with psychometric assessments and personality evaluations. And one thing that often comes up with women that I coach in the leadership roles they are in is how to be authentic. We talk about self-awareness, being an authentic leader, but also needing to meet the expectations of the organization and meet people where they are at. So how can women leaders better understand their authentic leadership style, but still meet those organizational expectations?
That's an also very good question. And I think it almost puts the onus on women to figure out what they need to change about themselves. And so I have a problem with that, in an organic way. I don't think necessarily that women need to fix the problems that other people created. I advocate for a very strong sense of self. That definitely includes self-awareness, and I'm not talking about venturing into dismissive arrogance or anything like that, but I strongly advocate that it is perfectly okay for women to know who they are and to not want to compromise who they are. And when we talk about meeting expectations, the expectations of others, I think we have to be careful about who those others are, because it's very easy for the expectations of others to bleed into us and affect our self-confidence when sometimes those expectations are completely unreasonable. And especially women physicians, they certainly possess the intellect to be able to evaluate, wow, these expectations are unrealistic. I think one of the most important things I've ever heard, and this is from someone much, much smarter than me, but it was, what other people think of you is none of your business. And I think we women have been made to feel as though we need to consider what everybody else thinks of us. And I think that's a mistake. Obviously, we will be evaluated on our performance and the outcomes we're associated with. And I do want to talk about that a little bit more later. But that does not mean that we have to compromise ourselves and consider every expectation worth meeting. Sometimes we can simply reject those expectations. Sometimes we can recognize them as really aspirational, theoretical, and not practical at all.
Are there some expectations that you see women bring forward often that are just common, that you often help women talk through and recognize as unrealistic, and then how they manage those?
Do you mean expectations of themselves?
Both. You had said that we come up into these unrealistic expectations, and sometimes they're other people's expectations, and sometimes they're our own. And for me, it queued up the question of imposter phenomenon, which comes up a lot with women that I coach. And so are there common examples of specific traits or styles that are expected for women physicians or women leaders that you see women struggle with?
Sure, yeah. And thanks for that clarification. Whenever I'm working with a group of physicians, regardless of where folks are in terms of gender, I always ask this question. I always say, raise your hand if you do things because, number one, you're worried if you don't, they won't get done. And or number two, you're worried if you don't do it, it won't be done correctly. And I never have, maybe I have one or two people who don't raise their hands, and that's because, they've been working with a coach or something for a long time. And I think that is an indicator of something, And when I'm working directly with women physicians and women leaders, what I see is that's not just about their work, that's true of every aspect, almost every aspect of their lives, where they feel like they have to be involved or they have to take control or it won't get done or it won't get done correctly. And I usually say, how special do you folks think you are? You're going to die. And is the world going to fall apart when you die? And I just interject a little bit of, humor there so that people realize, wow, I am not the engine that keeps everything running. And so I think sometimes we just need that sort of slap in the face because we've just been behaving the same way we've always behaved. And it doesn't help other people in the way we think it does. You know, my better half would always just do the dishes in spite of asking our son 7 to 10 times to do the dishes. And I love my better half. This is not a criticism. This was an observation. The refrain was, it's just easier to do it myself than to continue to ask and have my request ignored. And sometimes you just have to get drastic, you know. So I just put his dishes on the bed. I mean, you know, and sometimes you have to get drastic. Obviously, that doesn't extend to patient care, you know, but it certainly encompasses self-care. So that's what I do when we're talking about dealing with expectations for ourselves. When we're dealing with expectations of others, as I mentioned earlier, evaluating those expectations is truly important. You know, determining is this theoretical or is this something that can actually be delivered? And if it's not something that can be delivered for whatever reason, say no. I mean, no is, the word exists for a reason. And I think the problem we don't feel comfortable saying no is because we associate guilt with it. Mm-hmm. And we always hear, you know, oh, no, you don't want to say no, say yes and. Yeah. Why? Why are we saying yes and? Part of that is that guilt and our concern of what that will make, how that will make others perceive us.
Yeah.
And that is just not as important as we tell ourselves that it is.
And I love that you brought this up because it is an area that comes up a lot. And women that I work with talk about taking on too much, taking on other people's problems, being the fixer. So I want to transition that into a question about collaboration and being a consensus builder, but also being able to say no. And there's that tension for women who often are naturally collaborative and consensus builders, but sometimes struggle to maintain that while also being decisive, especially in a high stakes environment, and leaving no as a simple one-word sentence without qualifying it or without reciprocating in some way. So how do you address conversations in that space?
I think I struggle with that too sometimes. I mean, I think everybody struggles with that. Yeah. And I think it might require a little bit of tweaking to how we're defining consensus. Like we can achieve consensus without everybody thinking the same thing. And if we say no, well, that is the platform upon which we're going to build consensus. It does not mean that you have to fold, right?
Right.
So that's the first thing I think of with regard to that. And the same is true, you know, it's a little bit in alignment with collaboration. Collaboration does not mean I'm going to pick up the slack whenever you drop it. And so I think we kind of get ourselves into trouble because that's the historical way that we've approached things. And I don't want this to seem at all as though I'm blaming women for this. I think we've been forced into this position because people do expect us to take care of things. And instead of pushing back or arguing or, you know, trying to have 7 meetings a year to talk about redistributing the workload, just say no. Yeah. Just say no. And honestly, I know that's terrifying because you think, oh, well, that could be easy, but this is my job on the line or so on and so forth. But, you know, the rate of distress, depression, PTSD in physicians is unacceptable, at least here in the States. Yeah. I can't speak to the rest of the world, but it's completely unacceptable. And, you know, we teeter. Sometimes it's just over half. Sometimes it's just under half in terms of how many physicians who are parents don't want their kids to go into medicine. So I think saying no is really important. What is it that we're trying to preserve? And I feel as though it's not just docs preserving themselves, it's also preserving medicine. Because if we're setting these examples that it's okay to be worked to death and compromise all your principles, well, then we're really creating a detriment to the healthcare workforce you referenced earlier.
Yeah, and that's a great concept that I had talked with a previous guest about. When we overperform at the detriment of someone else, we rob them of that opportunity to perform themselves. So overperformance robs people of meeting their capacity or their, I'm losing the word for it, but their potential.
Potential.
Yes. Yeah. So I think that's a really interesting concept. And I know for myself included, sometimes saying no does feel so scary. Like you think that it's just you're going to lose your job because of it. And what you said about making no the platform that we collaborate around or build consensus on was really powerful for me. So that's something I'm going to take forward for sure.
It's not easy. It's not easy at all. And it does make you feel scared. And perhaps as though you're disappointing someone.
Yes.
But to continue to move forward, you just continue to disappoint yourself. And it's not okay. It is not okay for anyone to put themselves in the back seat over and over again. I mean, it's never going to be completely equal. Somebody is always going to have to do a little bit more or, fight a little bit harder, because that's just the nature of life, But to do it habitually, if you want to be fair to everyone, you have to include yourself in that everyone.
Yeah, I like that a lot because we often don't. And that point of you're also you're disappointing yourself if you don't say no, that also is very poignant, and I could feel that one hit. So I think that'll speak to a lot of people listening. Thank you for offering that. I wanted to ask a little bit about leadership styles too, and what you're seeing shift across styles today, where we're seeing more women enter leadership roles. And in the past, I think there was a tendency for women to take on authoritarian personas in their leadership roles because that's what they saw modeled for them. And, they talk about the toxic alpha male leadership syndrome. What are you seeing emerge as new trends, and how are women leaders impacting the way male leaders show up or feel safe showing up?
What I've been seeing that's interesting related to this is the age range of the docs who are coming into the master's program. It could be just that I'm getting older, but they just seem younger and younger. And we are seeing more and more numbers of women physicians in the program. So sometimes I wonder, and this is pure speculation on my part, I have no data to back this up. Sometimes I wonder if there's a generational shift and it's just been okay for the last decade to say that is ridiculous toxic behavior, and it does not matter what gender you identify with, you simply cannot behave that way. So that's a good hope, right?
Yeah.
A good hope that the women coming up behind us are just going to be like, I have absolutely no time for this. But I have been seeing a shift toward just recognizing it is ridiculous for me to pretend to be another gender in order to behave in an authentic way. So I think people are more likely to reject that idea now than even 5 years ago. So that's one shift that I'm seeing that is very encouraging. Now, I say that with the full acknowledgement that not everybody around those women accept that change. We can have a 36-year-old woman physician working with a 62-year-old male physician who will certainly say, well, she's not like anyone I ever worked with before, but that's not bad.
Right. It's not bad if there doesn't become a reason to not follow or a butting up against that. If that becomes the platform on which the older physician manages that relationship, then it becomes a problem. But again, then that becomes a new dynamic that has to be worked through.
Right. And then you know that what you've got is something systemic. You know, why is his behavior tolerated? And that's when we get into, cultural norms and things such as that. And I'll be honest, I've worked with docs from so many different hospitals and health systems. I do think there are a lot of poisoned wells out there. And I do think it's going to take complete tidal shifts in management and leadership. And sometimes I work with docs and I have to simply say, you are Sisyphus here, and you have to decide, is this really how I want to spend my days, my life? If I'm bringing my best self to this environment and this environment makes it pearls before swine, do I want to keep doing this? And that's a terribly hard conversation to have. And it's a difficult intersection at which to find yourself for anyone. But I think especially for someone who has put in the training and the hard work and done all of the vast amount of education, that can be really, really soul crushing to physicians. But again, I say, the flip side of that is to keep sticking your head in the same hole and getting bonked on it. That's soul crushing too.
It is. So where do you see that shift coming from? As you said, there's still a large number of systemic issues that have to be dealt with and how we lead in healthcare organizations. So where do you see that shift coming from?
Well, the first place I see it is in physicians accepting that they need more control over their work environment. And for the many years, we've seen people, for example, from the finance sector coming in to lead hospitals. And we know who thought that would be a good idea, right? But the doctors never thought that would be a good idea. And there's reasons that, many physicians 15 years into their career, 20 years into their career, still have not really been involved in a discussion about a P&L statement, a profit and loss statement, for example. Right. So I think that is an important part of the shift. Physicians realizing, there are levers being pulled that nobody talks to me about, but that directly impact my ability to have strong outcomes with my patients. So I think that's a good, important shift that I hope endures. I think another shift is perhaps a little bit of humility on the part of leadership. And I do think that's generational to a degree. And I'm not saying, all of the old dinosaurs need to die, although we will, but I think that they're finding themselves in the minority as time goes on, which is not a great answer, frankly, because that's like waited out. But I think that is the reality.
Yeah. Well, thank you for that. I wondered if that was part of it, is some of it waited out. But if we're going to wait it out, it does mean we need to have that infusion of people that think differently and lead differently. So I'm so glad for programs like the medical management program and programs that look to develop physicians as leaders so they can be part of that change. So thank you for what you do.
No, I love it. Thank you.
You mentioned CFOs, and so that got me thinking about money. And I wondered if we could talk a little bit about the gender pay gap that still exists and is quite real. And again, even though women are the majority of healthcare workers in healthcare as a whole, there's still a pretty significant pay gap that is recognized. Where do you see opportunity for women to better close that gender pay gap, and whose responsibility is it?
Really good questions. I have I should have been taking notes while you were asking the question because my brain was just whirring. One of the things that I do with a lot of physicians is encourage them to think about their evaluations. And I'm talking about performance evaluations, not necessarily from an RVU standpoint, because supposedly we're moving away from that model. But your work performance, the way you are at work, the level of dependence people feel they can have on you without being disappointed. Just like a performance evaluation, just like anybody in any other field other than medicine would get. And almost none of them get those.
Right.
Almost none of them receive an evaluation that has anything to do with how they get along with their colleagues, what new ideas they've brought to the table, what problems they've found and fixed. So that is a huge issue, because if we're really going to think about pay in an equitable way, then we have to think about everything we pay people for.
Yes.
Otherwise, we're just turning physicians into shift workers,
Well,
which is an abomination.
That's happened. As you said, many physicians, especially in an employed model, are paid strictly on the work RVUs.
Right. And so I think that's the first bit when we're talking about organizational ethics, that has to be changed.
Mm-hmm.
Second, I find that there is a generic understanding or acknowledgement that the pay gap exists, regardless of what your gender is. I find that discussion has become so loud that everybody is aware. Let's just put it that way. But it's very generic. And it's sort of like, we all know about pollution, or, we all know about the importance of recycling or whatever. But that it doesn't galvanize people necessarily. I mean, some of us recycle, but it just kind of lays there.
It's that normalized deviance, right? We know it, we see it, we accept it, and we move past it without doing anything.
Right. And so what I'll say is, in conjunction with the way physicians have been paid, the first thing is, many physicians I meet who identify as men have no idea how much more they make than their women counterpart. They have no idea. And when they find out, many of them are just flabbergasted and they don't even know how that could have happened. So I think, when we talk about negotiation skills, which is negotiation is a huge topic in and of itself. But the first thing I think everyone needs to do is just, if you have a number in your head, I'm just going to come up with a silly number. Let's say you're thinking $220,000. Well, go in and ask for $250,000, because I don't think we necessarily, we feel as though I don't want to ask for too much, or I don't want to, or it's gonna knock me out of the conversation or knock me out of consideration entirely. Well, I don't think that's true. And if it is true, if somebody is willing to no longer consider you because you've asked for them to demonstrate that they value you highly, well, you don't want to work for them anyway, So I really encourage women physicians, just ask. Just come up with a number that you want and tack on a bunch more and ask for it. And, I was talking with one woman physician, and I realize this is anecdotal, but I have to believe this happens more than people tell me. I was talking with one physician, and she was moving. And so her husband, also a physician, and so he came home and he had gotten a nice offer, and they were sitting talking about it. And she said, well, how do you feel about everything? Is there anything that you wish they would do? And he just said right off the cuff, I think I'm going to ask him to see if I can get $25,000 more, just to see. And he got it.
Oh, because he asked.
Because he asked, exactly. So honestly, addressing that pay gap, it's multi-pronged. We have to address it right at the beginning when we're negotiating our terms, right? Because the answer, the gurus will tell you, the answer is not, let's just make everybody equal in terms of pay right now. Number one, no one's going to do that. And number two, there's just a lot of issues associated with doing that. So I think to start, wouldn't it be wonderful if we just started out paying women more, paying them what they are worth? And sometimes that involves, this sounds so weird, even as I say it, but like inflating your self-worth. If you think you're worth 220, it's highly possible other people think just the role, not even you, but just the role is worth 275. So you're devaluing yourself by throwing out that 220. And certainly nobody's going to say, we would have gone to 275. They might say that when you leave the room, but
yeah.
So that's one thing that I'm thinking of.
Yeah. Don't negotiate against yourself in a sense by putting out too low of a starting point.
Absolutely. And if they put out too low of a starting point, what I think the next best thing is saying, is that the value you assign to this role? Before we decide, the worth you see in me as an employee, let's discuss the role's value. What value do you assign to this role based upon the expectations?
That is powerful. And you preempted the question I was going to ask, or the statement I was going to make, which is a lot of times, and so this is my experience, but also women I speak with, we feel like we have to come with a business case to ask for that extra 25K. And this is overreaching again, right? Making their problem my problem. I feel like I have to come in and justify why I'm asking for more, rather than simplifying it and turning it around and asking a very simple question. What do you think this role is worth?
Yeah.
Amazing.
If things go well, and you're delighted with the outcome and my performance or anybody's performance in this role, what's it worth?
Amazing.
I think we do ourselves a disservice when we think of it as asking for more. We're just asking. As soon as we qualify it as saying it's more, that's where that idea of the business case you mentioned comes in. Because we're almost making ourselves feel as though we're asking for something that might not be fair or reasonable because it's more. Well, who decided that?
Right. These are these little tiny things that we do unconsciously that create limitations on the possibilities.
Right. And in some ways, again, to go back to one of the first things I said, I hate for anything that I'm sharing to sound as though that it's a woman's responsibility to fix the inequities. That's, for lack of a better phrase, that's victim blaming, But what we can do is simply not tolerate it anymore. And if that becomes the norm, then it's the norm.
Yes.
And then the message is sent. Wow, there was a time I could have hired her for 220. Now I can't find a woman who's willing to take anything less than 275. Okay.
Making it the norm. And that's a powerful statement that I'm going to use to transition us to closing. The time has gone too fast. Let me just say that, because I could talk to you for a long time. But making it the norm, and why that ties in is this podcast is about making waves. And so WAVES is an acronym that I use to represent women amplifying voices and elevating success. So when it becomes the norm, it's because we've had a collective vision that we've all upheld in a sense. So thinking about this commitment to enriching leadership through diverse perspectives, through authentic storytelling and collective achievement, I'm wondering if you could leave our listeners with one challenge or one call to action that would advance our collective success in healthcare leadership. What would that one call to action be?
Wow. Okay. This might sound as though it's coming out of left field, but this is what I'm going to say. If you would not say it to your son or your baby sister or your sweet grandmother, then do not say it to yourself.
Oh, wow. That was not out of left field. That was very powerful. And I'm going to spend some time thinking on that one. Rebekah, thank you so much for making time for this conversation. As I said, I could talk to you for much longer. Thank you very much for joining our pod community and sharing just a few insights from your leadership journey.
Well, thank you for having me. It's been delightful.
Thank you for listening to today's episode of the pod. I invite you to join our pod every month as we empower one another, fostering a world where women in healthcare leadership thrive.